So as our panelists are getting situated, brief this panel is Julie Grimes. She suffered disabling fatigue, muscle weakness, and respiratory insufficiency due to a chest wall weakness that occurred that 2 years ago progressed to a respiratory failure requiring assisted ventilation. So with the care and guidance of her palliative care team, she chose tracheotomy for quality of life. It's not stopping the progression of her illness, it's purely palliative. She's a writer, an accomplished knitter, an ardent reader of literature and film, and a fine chef. She has a full life. To my far left, your far right, is our kind of moderator, Jeff Yee, who is a board-certified physician in internal medicine and hospice and palliative care. He's practiced in Woodland, California for 28 years, focusing on building community programs of care and aligning these with the medical community. Many of you know Jeff. You can see he was one of our leadership award winners and got his personal signature hat along with the award. Jeff has been one of our founding leaders and physicians in the palliative care movement here in California. So please join me in welcoming our panelists.
So I also want to acknowledge Melissa Meibert, who is Julie's nurse from Snowline Supportive Care. And we'll get to really meeting those two women, who's really the focus of this session, in just a few minutes. But after Judy gave us that grand background, I felt, I got to give you guys some local history now. So this accoutrement is courtesy of Catherine McGregor. So in the early days of the coalition, we're really heavily focused on initiating and disseminating polls. And so you couldn't come to a meeting without being decked out in pink. If you weren't in pink, you weren't allowed in. So we still see some remnants of that here. We still see a few people with that. So there's a couple of things that you should know about this now in perspective. One, if someone in pink polls tells you that they're really young and new to this, don't believe them. They've been around. Second, we know our work is, even though we haven't talked much about Pulse now, we know our work is not done. Our work will be done when you go to Kinko's. Instead of ordering Ultra Pink, you order Post Pink. So we know our work is not done quite yet. Okay, so with that, we want to get into the meat of our session. So we wanted to accomplish a few things in this session. First was, of course, to give you, hopefully, a sense of renewal and affirmation for everything that all of you are doing, because that is really, really important to come here and to feel that. Second, we're going to want to give you some insights into really a great home-based palliative care program that I encountered through my year at Snowline Supportive Care. The third thing, though, too, was I wanted to then say, okay, so but how do we get there? So I need to update this slide for resources. I need to put Katie Butler up on top, but because I didn't know, because I didn't have time to add that in, we wanted you to have some resources that we think might be helpful. So these are resources that happen both on a national level and a local level here to show that this work is moving forward. So there is, and you'll see hopefully through our presentation, a little bit of the facets of these tools that we use. The Serious Illness Conversation Guide, which is led by Susan Block. A new resource that's coming up is Patient Priorities Care, led by Mary Tinetti. And then locally, I want to show you some of the things about choices in caring. And really, these are tools that help us lead towards patient-centered care, patient-centered thinking, which is really the basis of great palliative care. So, and many of you may be already doing this, maybe using tools like this similar, but this is also an opportunity for you to mentor those around you, either new colleagues, young colleagues, or those who are non-palliative care people, and teaching them what's the basis for good person-centered care. All right, so my job now is going to be to encourage Julie to really tell you that story. So I think, you know, one of the things that we have to do is to make Julie feel welcome. So when we introduce Julie and Melissa, what I'd really like you to give her is like your most hearty hello. So like when I introduce myself as Jeff Yee, and I say to the audience, hello everyone, you'll respond back in your most hearty voice, hi Jeff, okay? So, hello everyone. Hi. Okay, Julie, do you want to say hello to everyone?
Hello everyone.
Hi, Julie. Great. Do you feel more welcome and at ease now?
I do. Much. Thank you.
Okay. We'll get,
come on.
She's not
You
last.
can
Okay, Melissa, say hello to everyone.
Hello everyone.
And while we're at it, you know, well, in just a moment. So, many of us early in our lives are thinking, you know what, we are looking for that lifelong companion, that inseparable companion. Well, Julie has found more than one inseparable companion. Lou, do you want to stand up and introduce yourself? But Julie, why don't you tell us a little bit about your other inseparable companion? We won't ask you about, you know, the benefits and the faults of inseparable companion number one, but maybe you could tell us a little bit about inseparable companion number two, which we see up here.
Well, that is my ventilator. My friends have named him Wally, after the little robot in the movie. I prefer the name Wilma. I think it's a girl, not sure. And it goes with me everywhere. I'm never without it. It has made my life better in some ways. I can breathe more easily. I have energy. I have a voice for the first time in 15 years. I can participate more fully in my life. I was pretty sick, kind of moving to the hospice thing, and then Melissa here got the bright idea about getting me trached and ventilated. And that was going to be a no for me. It had come up before, and I had said no because it had been presented to me as something really onerous, not only to me as a patient and my family, but to society and the healthcare system. It would be a huge medical burden. And I didn't want to participate in that. But Melissa found a way to convince me to investigate, and here I am. Me, Wally, portable suction machine, and emergency go bag. They go everywhere I go.
So really, we'll get into that story of transformation in a little bit more detail. I asked you about how life was before you became ill, and you sent me some pictures. Do you want to tell us a little bit about...
Did I send you pictures? Oh, dear. Oh, that's me and Lou when we were very young. We used to like to travel a lot, go to San Francisco, and that's the Japanese tea garden. We were taking photographs. I was taking photography classes at the time. And we used to hike, go to museums. I was a runner, an avid cyclist, endurance athlete. And we were just hamming it up, being goofy. A little Charlie Chaplin in there somewhere. And we used to go to the beach. We would beach comb, hang out. I was collecting shells and, again, hamming it up. I'm a terrible ham. Oh, that is me. I was sick then, but not as sick as I am now. And that's my niece, Zoe. And I had scooped her up and was giving her some snuggles. And she was very happy. I can't do that anymore. Of grab her. But of course, she's 6 feet tall and has 20 pounds on me now, so.
Zoe's pretty important in your life, is she, or what?
Yes,
She's
very.
more than just a niece, I think, from what you've told me.
Oh, are you thinking Sierra?
Oh, okay, another one. Okay.
I have a ton of nieces and nephews and a goddaughter, and Lou and I are helping to shepherd them into adulthood with some grace, and maybe a tiny bit of grit, we're not sure.
Okay. And this one?
Oh, I like to cook, and I like food. I'm something of a foodie. And in that photo, I am making a birthday dinner for Lou. I'm sure it was some pasta affair, his favorite Italian, but I can't remember the dish right now. And I was part of a writing group at Sutter Hospital. It was called LAMP, Literature and Arts in Medicine program it was. And we would meet once a week and write, and I started writing poetry as part of this. And we published a book, and this was the book launch party with Lawrence Spann, who was the head of the thing, and John Crandall, who was his sort of second-hand, right-hand man.
So, one of the things that I think is really important, and I'm glad you were able to share these photos with us, because it says something about you. So one of the things that we try to do in our work locally is using this tool called Choices in Caring, and you have that in your package there. But one of the questions we ask people to start thinking about and tell us about, if we ask someone who knows you well, Julie, at that time, what would they say that made you a special person? What made you you when we're looking at these pictures?
That's you're putting me on the spot here. Well, people used to describe me as very hardworking and embarrassingly earnest. Compassion is a word that comes up a lot when people describe me. I'm a fierce advocate for others. I've helped take care of ill people in my family and advocated for them getting the best health care they could get, and good deaths, too. And some would say that I'm sort of a bossy schoolmarm, and they would not be wrong, and they know who they are.
So now we kind of have a little bit better picture of what's important to you as you're reflecting back on that time. So here's our little audience participation bit. If you have ever had a colonoscopy, can you please stand? All right. Now, if your colonoscopy experience was so tremendous that that was like the pinnacle of the year and that you really just feel like you want to share it with your neighbors and say, you know what, you got to go to Sutter or Kaiser or wherever to have your colonoscopy. Stay standing if you had that kind of experience. Oh, no one? Oh, wow. So, Melissa, so people they obviously don't do colonoscopies for the tremendous experience. So why would you put up with doing a colonoscopy? What do you put yourself through, and why should you do that? Why should you put yourself through, the discomfort and the inconvenience and the little bit indignity of having a colonoscopy?
I would think to find out the answers that the doctor would give you after the colonoscopy. And we talk to patients all the time about tests that they want to go through, more scans, more labs. And the question I always ask is why? And why do you want to have this testing? And it's always because I want to know. And then the next question is, well, what are we going to do with that information going forward?
So I think you're exactly right. So no one does a colonoscopy, no one does heart surgery, no one stays in the ICU on a ventilator just for the experience. I think Julie would attest to that. You do it, why? Because you hope that that's going to help you be better so that you could do more of the important things. So I think that's really an important thing. But that isn't what we necessarily see in palliative care, is it? It's just what happens more in the palliative care population that we see, Melissa. What do you think?
Most often in palliative care, most of my patients are on a road towards hospice. And so when we're working with them and they're going through these tests, we're supporting them during the journey, whatever, offering education and along the journey so that they're not doing tons of unnecessary testing, but also kind of meeting them where they're at and offering them the education, allowing them to go through the testing that they want to go through. But inevitably, the conversation tends to switch to a conversation about hospice because the options after the testing are not what they had hoped.
So this is a picture of the Snowline supportive care team. Can you tell us a little bit about Snowline, its philosophy, where it's come from, and tell us a little bit about Snowline.
Big question. So Snowline, wonderful. I've been with them for about 5 years. I've been working in hospice and palliative care for about 8. Snowline is a nonprofit that's been around for about 40 years. Actually, exactly 40 years. It's our anniversary year. We're having a celebration, and you're all invited. You can ask those people back there. So Snowline is, again, a nonprofit, and hospice was around in El Dorado County, and then more recently Sacramento and Placer County. And we branched down into Sacramento, and then a few years ago, and all along while we've been taking care of our patients, we recognize, just like all of you do, the gap between healthy and hospice. And in that gap, we saw a need. We were talking to our hospice patients over and over again about the paths that they had gone through to get to hospice and navigating the system on their own. I have personal experience. I lost my husband and my father last year, and going through it by myself, or not by myself, I had a team. And I was fortunate because with all of my experience and all of my knowledge, I still needed help talking to them about a pulse or talking to them about options for care. So the patients that we take care of don't know what I knew, and so there is a huge need. Our palliative care program is non-funded. We're lucky we have a robust retail business. We have our retail stores, our thrift stores, and that helps support our palliative care program. And we focus on the 3 C's, the cardiac diagnoses, the COPD, and the cancer. And once in a while, we get lucky enough to have an extra, like Julie. I am so grateful that I got to meet her and take care of her. So yeah, that's Snowline.
For all of you who want to go to their free anniversary celebration, would the Snowline people just stand up for just a moment? So that what I want is that for you guys to be able to talk with them at lunchtime and at the break. They really do have a superb program, and you could gain a lot of insight from talking with that team back there.
Our program, we have, within our program, we have doctors, nurse practitioners, nurses, social workers, spiritual care providers, and home health aides. And we provide 24/7 care for our patients. So they can call at any time and reach a nurse for advice or even for a visit.
So let's get back to your story, Julie. So your story really started, I understand, when you got really sick with toxic shock syndrome in 1990. Yeah. And you survived, and you were supposed to get better, but how did that really work itself out? What happened, really?
Well, I didn't get better. I developed new symptoms of joint and muscle pain, fatigue, weakness, which progressed to some neurological symptoms and respiratory insufficiency. And then in 2017, that was when I was diagnosed with a respiratory failure and was on 24/7 BiPAP therapy. And it was soon thereafter that my GP, Dr. Krys, referred me to Snowline.
So what was happening with standard medical care? How were you getting the treatment that you felt you deserved at that time as you were getting progressive symptoms?
No.
What was happening?
My diagnosis is not obvious, and it confounded a lot of doctors, some of whom were wonderfully supportive and caring, and some of whom were really awful and mean, demeaned me. And so I had lost trust in the medical system. I'd pretty much given up by the time Snowline came on board, I think. I was just tired of fighting for care and it being treated so poorly and not getting any treatment, going and then everyone being like, that's an interesting diagnosis, don't know what to do for you. So I just sort of cut back on all of it, and I decided that I just wasn't going to participate anymore.
So you actually then had to switch your primary care physician, I think.
Oh, yeah.
And so that suddenly happens, and the first thing that comes out of his mouth is,
yeah, the very first time I met Krys Price, he took like one look at me and he said, "You need services." And I was like, "What?" No one's ever said that to me before. And he talked about Snowline. And my first response was, "I'm not that sick, am I?" Because I thought it was hospice. And I've shepherded both my husband's father, who had Alzheimer's disease, and my brother, who had colon cancer, through a hospice and the dying process. So I thought, it hadn't occurred to me that I might be in that state or close to it. And he didn't sell it to me that way. He said it was about supporting people with a serious chronic illness and their families. I still wasn't convinced, so I went away for 2 weeks to think it over. And I looked on the website for Snowline and got some information about that, and I thought, well, yeah, it's worth a try, and I can opt out if I don't like it. So
Melissa, so here's Julie, who comes along. She's kind of fed up with the system. She's more or less thinking she's going to die, and we get this referral. What did our first care plans look like? What was your first impressions as you met Julie at this stage?
It's funny listening to her talk right now. I remembered our first visit. Julie was not super happy I was coming over, and she just, I heard everything that you just heard, maybe in stereo a little bit more, and just pretty much dismissive and like, you can't really do anything for me. Her first care plans were basic. They were like, you start anyone off with a respiratory diagnosis. And she had some pain, and she has a little bit of some mobility problems. And so they were very basic care plans. I didn't know her. They changed drastically as I got to know her.
So at that stage, if I had asked you that question, what would you say makes Julie special at that stage? What would you have said?
At that stage?
Yeah.
grumpy.
No, I don't know. At that stage, all of our patients are special. I was hopeful for her, but I was still, honestly, I don't have a lot of experience with trachs in the home or with BiPAPs. I have more. But it was a learning experience for me too. And of course, as medical professionals, I didn't let her know how little I knew. I just started researching. And I just listened. I listened to what Julie's goals were for her future. And Julie's goals were different than they were even within a month, because her goals at first were just to kind of manage things as they were and experience the decline as few symptoms as possible. And so that's where I was at that point. I was thinking, how do we manage her respiratory systems, and what will an emergency look like, and what can we get into her home to help to keep her out of the hospital?
So pretty typical for a lot of our palliative care patients that we're thinking are headed towards hospice and dying in a pretty short period of time. Julie, what was different about palliative care were you seeing?
Excuse me, my voice is getting dry. Everybody was focused on me and my family. It was really inclusive. No one had ever asked me what my goals for life are, or quality of life issues, or asked me to describe or define them. So that was a really interesting process that I got to go through with Melissa and you and Kate and Cynthia.
No, go ahead, I'm sorry.
So what happened was I got to define all those things, have conversations with my family that I would not have been able to have if they had not been there to shepherd me through that, because I didn't have the language to talk to my family. And they're tough people. They're tough cookies. They fiercely wanted me to choose the living and a trach, and so we had a lot of discussions about that. And the treatment decisions made on my behalf were deeply informed by how I live with my illness. And that made a huge difference in my experience.
So I think actually, as I was part of that team at that time, we tried to bring focus and conversation to a series of questions which we take basis from the Serious Illness Conversation Guide, again, which we provided for you. These, I think, were sort of the key questions, and if you can think back and reflect a little bit, Julie, what were your biggest fears and worries about the future with your health and with life? If your health situation worsens, what would be your most important goals? And what abilities were so critical to your life that you couldn't imagine living without them?
Well, my biggest fears were being a burden to my family, and helping my family come to terms with my dying so that we could experience that as a somewhat positive thing, and I could help them through that transition as well. And I wanted to make sure that my wishes about how I was going to die and what was going to happen after that were well defined, so that there was no guessing was going to go on around any of that. I didn't want my family to have any conflict or worries about that. And I didn't want to have any unfinished business either, in terms of just, financial things and, but it also emotional. I wanted to have all the emotional issues with my friends and family, some resolution in all of that.
So a cardinal rule, and I'm one to break rules, so forgive me, is not to make your patients' decisions for them, but to guide them a little bit. So I think I remember one thing that you told us so passionately was your niece, Sarah, is that?
Sierra.
Sierra, that she was in the midst of grad school, and what did you think of her writing? And
she's a terrible writer. It's just god-awful. And I still have not accomplished that. She's graduating from, she's graduating the School of Psychology, yeah. She's going to be a school psychologist in May. She got through it. That was my big thing. I wanted her to get through graduate school and agree to get a PhD. I'm close. I'm so close. The writing thing, it's hopeless. She's just not going to do it. She's just hardwired not to do that.
So, and I really think, we kind of saw that, and I think that's what we were encouraging was that, despite being in a wheelchair and a trach now, do you still have a role in Sierra's life?
I do. She's going to start writing her thesis in the summer, And she has a project that she's going to be doing, and Lou and I are going to be helping her through that process. Lou's an English teacher and a cultural studies teacher at a community college, and they do research together, and I do a lot of editing and making sure that her sentences make sense.
So
I'm very much looking forward to that.
And I think that what that kind of helped us see was that if you go to the ologist that Katie was talking about, they're going to talk about how the disease responds. And what we were more interested in was how this person was going to respond and what would be.
I can still do things. I'm more limited in some ways. But you know, the care and feeding of a trach vent is super intense. It's constant. There are constant problems to solve. The supplies and the cleaning and the managing doctors and clinics and DME companies and infection, you know, it goes on and on. It's more than a full-time job. I'm hoping that I will be able to find a way to deal with the trach in the vent so that it doesn't take up all. Right now I don't have any. All those fun things that I got the trach for. That was a turning point. So we'll see.
So here's my advice. Go on a speaking tour, and then you can go to all these neat cities.
There you go.
So,
a whole new career.
We had a conversation, and I asked you, and I asked Lou, I said, okay, so what part of you is, you know, joyful, glad that you made this decision, and what part of you was regretful about that? And I had a number in my mind, and Lou gave a number, and I thought, oh, that's about where I'm at. And then you came around with a different number.
Oh, it was shocking, I know.
Well, and that's okay. Maybe that was not the greatest day.
Yeah, it was bad.
But it said something to me as a palliative care, part of the palliative care team, I don't know if you felt this way, Melissa, was, whoa, here is, we've been working with this patient for 10 months. We thought we know what's going on, and we're missing something. We missed something because that was an unexpected response. Any advice or any words that you could help us as palliative care providers to have better understanding of a patient's situation?
Well, in my specific case, I did not know what I was getting into. And it was very difficult to get information about what it's like to actually live trach and vented. And I don't know how we could have gotten more information about that, but that's been a huge problem. It's been a shockingly difficult transition to living with the trach. And I haven't made peace with it yet. I'm working on it.
Okay. And towards that end, you gave me, I asked for like a little biography, and you sent me back, and this was the title, A Condensed Biography of Julie Grimes, a Reluctant Palliative Care Graduate. Now I'm thinking, okay, I mean, of course, you're a reluctant patient because you didn't want this unexpected illness. And then, you know, especially when you're palliative care, you're thinking hospice, you're thinking, I certainly don't want that. But are you saying something else when you say a reluctant palliative care graduate.
Yeah, I think I was discharged from Snowline too soon. The transition, as I was describing, was really, really difficult and painful, and it's taking a very long time to learn how to do it. And I've had to spend me and my husband spent enormous resources, time, energy, just trying to figure out what to do. It took me 6 months to figure out who was in charge of the vent settings. And asking the doctors was futile. It was impossible. And there's so many new doctors. There's the PM&R people, there's the otolaryngologist, there's the GP, there's the DME company. There's a bunch of other doctors in there somewhere too. Oh yeah, respiratory therapists. And I think we both needed a lot of support to get through that. If we had, what comes to mind is a case manager. I really needed a case manager. I needed someone to guide me through all of that, because not only was I recovering from a surgery, I'm still sick. I still have limited energy, and I think if palliative care, if you can transition someone out from hospice care to a more functional, positive living experience, I think that transition needs to be taken seriously and given more weight.
I think that's a really important message for all of us to hear, because we oftentimes see palliative care as the prelude to hospice, but really, you know, when we talk about what our roots are is how to make a life better at all stages of disease. And so this was a special case because we actually, in some ways, got someone better, but we could have paid maybe better attention to the burden that was still there. And I think that's something that, as we're developing our programs, we really need to stay aware of. So we're going to allow for a question or two if anyone has a question for Julie. So Julie, I'm sure Julie is open to having you guys come talk to her at lunchtime. Mm-hmm. One of the things that I've found is that I've heard now for years, those stupid EMRs, you can't tell what the story is in the EMR. And so we all know that in order to provide care, we have to know the story. And what's really, I think, drives us here in this room is that we know this, is that when we can start helping patients write their story, that's why we all love our jobs and what we do. And so really thank you, Julie, for the opportunity for us to be able to participate, you know, in your care. I thank all of you for all that you are doing in your own little neighborhoods. And we hope that this session helps give you a little bit more insight. And thank you, Melissa. You want to say something else?
I would like to thank my Snowline team, all of you. You did wonderful work for me. I'm a passionate advocate for palliative care, and I'd love to see palliative care expanded to include more diagnoses, earlier intervention in people who have chronic illnesses of all kinds, MS, Parkinson's, Alzheimer's, you name it. We all need people to help us, we need experts, case managers, to help us manage a really difficult medical system and insurance scenario. Oh, dear God. So I'm going to be an advocate for it, and any way I can help, I'm happy to. So thank you very much. It was a gift.
My name is Margot Vos, and I'm a certified hospice and palliative care nurse who worked out in the community for many years doing case management. And you voiced something that I've been thinking about for a long time, which is that we have this role of what we call nurse navigators. And very often you see nurse navigators in oncology departments. But my daughter was recently diagnosed with a kind of unusual genetic condition that looks like we're going to be managing lifelong. And I have had to negotiate all the ologists in the last year to try to find my way through that with her. And it occurred to me that this role of nurse navigators is one that we really need, as you just voiced so beautifully, in palliative care, in people who have chronic illnesses, and that we don't have to step away. Like, it's a shame to me that you were discharged from this wonderful service that you had, because yes, you're better, but you probably are going to need some navigation for the rest of your life.
Yes.
And so I would really like to advocate to all of the policymakers and program directors in this room to consider this idea of creating a role, and I think nurses fill that role really beautifully just because of our training. So I just wanted to make that comment.
Thank you very
much.
I agree.
I want to echo, I'm Krys Kington-Barker, and I'm from San Luis Obispo County, and we are a social model hospice. One of the things that we noticed, because we work in tandem with medical hospices and with palliative care organizations, is there was a continuous situation for individuals in your circumstances who were being dropped when they no longer qualified for home health or palliative care. They weren't ready to move onto a hospice. Their case management would stop. Their decline wouldn't stop, their dying wouldn't stop, or their disease progression wouldn't stop, but the support would. We instituted a care management within our program about 1.5 years ago, and we hired a nurse. Most recently, we started originally with somebody who was geriatric trained. We switched to an RN who has been magnificent. She does care management for individuals telephonically and also does face-to-face care management. So she's care managing individuals, about 49 to 50 cases with just telephonic care management. And then she also is managing care for the cases that we have on in-home for our clients, as well as just answering questions for people and directing. But it's not only just giving people a list. She's actually making the connections, making the phone calls, making the appointments, and getting them connected. Yes. You can't check a box and say, call these people. You actually have to do it. So kudos to you for saying that. Thank you.
My doctors actually give me homework to do that's impossible for me to accomplish.
Exactly.
Because the other doctors they want me to talk to aren't going to give me the information because I'm the patient.
Well, and you make multiple
they need to talk
phone
to each
calls.
other, and they don't.
Yeah.
They ask me to do it.
Yeah. And when we're talking about caregivers or individuals who have a problem with a illness or a debility, or they cannot sit by the phone and wait to go through the telephone tree and call again and wait for the call back. So.
Yes. So I think the
my plea is for other people to look at a way to make that happen, because we're seeing it on a community-wide need. Thank you.
So the overriding message is that the palliative care needs are great, and we're nowhere close to being able to meet all those needs. So.
Yeah, and there's a need community-based. So if palliative care is only offered in a hospital-based, it doesn't meet community.
So join me in thanking our panelists again for the presentation.